So again, welcome to the Orlando GI Journal Club. This is May 1st. We're coming from Orlando, Florida. We'll proceed. Next, our first study is a study published in Gut by Vander Ploeg et al. We are looking at 8 years of duodenoscope contamination, insights from a retrospective analysis in a large tertiary care hospital in the Netherlands. Studies have reported a contamination rate of reprocessed duodenoscopes of 5 to 15%, with GI microorganisms in non-outbreak settings indicating that currently used reprocessing procedures are not suitably efficient. Outbreaks of multi-drug resistant microorganisms from contaminated duodenoscopes have been described worldwide. And in response to reported outbreaks, health agencies have made several recommendations to reduce the risk of duodenoscope-associated infections, including use of disposable components such as a disposable distal tip, use of single-use duodenoscopes, and regular microbiological surveillance of duodenoscopes to verify effectiveness of reprocessing and detection of contamination at an early stage. The aim of this study was to identify the risk factors for duodenoscope contamination and evaluate effectiveness of interventions, including transition to reusable duodenoscopes but with disposable caps. This was a retrospective study at a single tertiary center in the Netherlands. These authors at this center had transitioned to duodenoscopes with disposable caps, and after each ERCP, the duodenoscopes underwent a strict disinfection protocol, which included being pre-cleaned and then taking the endoscope to a disinfection area for manual cleaning, and then high-level disinfection using automated endoscope reprocessors. These authors were able to identify data from 404 duodenoscope culture sets that included over 2,000 sample sites from March 2015 to June 2022. The definition of contamination by these authors was the presence of microorganisms of oral or GI origin and any other microorganism that was at least 20 colony-forming units per 20 milliliter. So this is the results of analyzed duodenoscope culture sets by contamination definition. If you look at microorganisms of GI or oral origin, and then those with at least 20 colony-forming units, you can see that contamination rate of microorganisms of GI origin was 31.7% overall. And if you look at the presence of microorganisms of at least 20 colony-forming units, the contamination rate was 56.7%. When looking at the sample site, the most commonly affected contamination site was the air-water channel, was the biopsy channel at 16.5%, and the brush at 17.6%. If you look at the suction channel, 17.4%. And the other sites in the scope, such as the forceps elevator, was 4.5%. The protective cap was 5.3%. When looking at the types of microorganisms of GI origin that were found in the duodenoscope culture sets, the most commonly occurring microorganism was Pseudomonas at 7.2%, followed by Enterobacter closei, 5.7%, Klebsiella pneumonia, 4.9%, Staph aureus at 2.7%, and Stenotrophomonas multifilium at 2.5%. Now, this is a timeline generated looking at the number of culture sets plotted over time between March 2015 and May 2022. And as you can see, regardless of the type of interventions introduced to the disinfection cleaning process, such as auditing of manual cleaning process in January 2016, when they started an intensive cleaning program in 2017. They transitioned to disposable cap duodenoscope in 2018. They also used single-use endo brush for disinfecting duodenoscopes in 2020. Regardless of all those things, you can see there is a fluctuation and fairly consistent level of contamination of duodenoscopes. These measures, such as audits, automated endoscope reprocessor replacement, and implementation of duodenoscopes with disposable caps, did not show a clear association with contamination rates. The main limitation of this study is that this is, of course, a retrospective design. The report history of these culture results is not available. There's also potential errors in sampling processes that cannot be identified due to its retrospective design. And also the authors state that the whole genome sequencing was not used to identify genetic-related microorganisms. But what is clear from this study is that contamination of reusable duodenoscopes remains problematic and is a resilient issue for which to date no solution has been identified. And even though several interventions were carried out over time, it did not lead to elimination of contamination. Changes in reusable endoscope design that facilitates sterilization or disassembly might be critical for effective endoscope reprocessing and prevention of duodenoscope-associated infections. Okay. Our next study is by Li et al. This was published in the Clinical Gastroenterology Hepatology Journal. It's looking at the reduction in upper GI bleeding risk with PPI therapy in Asian patients in South Korea with atrial fibrillation receiving direct oral anticoagulants. In patients with atrial fibrillation receiving direct oral anticoagulants, upper GI bleeding is a serious adverse event, and high rates of GI bleeding have been reported for some direct oral anticoagulants. There are, however, limited data on the benefit of use of preventive PPI to reduce the risk of upper GI bleeding in direct oral anticoagulant users, and the aim of this study was to evaluate the potential benefit of PPI co-therapy for prevention of upper GI bleeding. This was a retrospective study conducted in South Korea looking at a nationwide database known as the Korean Health Insurance Review and Assessment Database. They were able to identify 165,000 patients receiving direct oral anticoagulants from 2015 to 2020. And they used a propensity score weighting method to compare patients with PPI use and those without PPI use. The mean follow-up in these patients was 1.5 years. The primary outcome was hospitalization for upper GI bleeding. So they were able to include 165,624 patients who were receiving direct oral anticoagulants between January 2015 and April 30th, 2020. And then from this cohort of 165 patients, 99,868 patients did not have PPI co-therapy, and 65,756 patients did have PPI co-therapy. And what they did was they looked at patients with and without PPI therapy and compared the two groups. So if you're looking at the general comorbidities, you can see that in terms of comorbidity, the only significant difference they found between PPI and no PPI groups was that it was the incidence of diabetes. There's also a difference with p-values less than 0.05 in the incidence of sleep apnea, prior stroke, prior intracranial hemorrhage in these groups. Otherwise, other comorbidities such as hypertension, heart failure, prior MI, peripheral vascular disease, those kinds of things remain not statistically significant between the two groups. Now, if you look at the cumulative risk of upper GI bleeding, if you look at the primary outcome of hospitalization for upper GI bleeding, they found a significant increase in the incidence of hospitalization for upper GI bleeding in the non-PPI co-therapy group compared to the PPI co-therapy group, with a weighted hazard ratio of 0.825 in the PPI co-therapy group with p-value of less than 0.001. Similar results were seen when they looked at the incidence of upper GI bleeding requiring blood transfusions. And again, the use of PPI was protective against upper GI bleeding requiring blood transfusion with hazard ratio of 0.798, p-value less than 0.001. When they performed a subgroup analysis looking at the risk of upper GI bleeding in patients with and without PPI, but for different types of direct oral anticoagulants, so they looked at rivaroxaban, dabigatran, apixaban, and edoxaban. They again found that the use of PPI was protective for hospitalization for upper GI bleeding and upper GI bleeding requiring red blood cell transfusion across all the types of direct oral anticoagulants. The limitation of the study, again, is that this is a retrospective study, and the benefit of direct oral anticoagulant and PPI co-therapy in other ethnic groups is not clear because they used a nationwide database from South Korea. They also studied patients who were receiving direct oral anticoagulants for atrial fibrillation only, and therefore the authors are uncertain that PPI co-therapy could also lower the risk of GI bleeding in patients with indications other than atrial fibrillation, such as thromboembolic disease. Also, because this is a retrospective study, they did not have information on the duration of direct oral anticoagulation and PPI co-therapy, adherence to each drug, and potential over-the-counter prescription and free gastroprotective agents, and these were not incorporated in the analysis and is a potential source of bias. So the take-home point from this study is that in patients taking direct oral anticoagulation, PPI co-therapy was associated with lower risk of hospitalization for upper GI bleeding and upper GI bleeding requiring red blood cell transfusion. The benefit of PPI co-therapy on hospitalization for upper GI bleeding was consistent among the different subtypes of direct oral anticoagulants, and given the most frequent single site of direct oral anticoagulation-related major bleeding is the GI tract, the use of PPI in direct oral anticoagulation receiving patients for gastroprotection as the primary GI bleeding prevention strategy could be a reasonable option. Our next study looks at a study from Italy by Paella et al., published in the Red Journal, American Journal of Gastroenterology, looking at the outcomes of a 3-year prospective surveillance in individuals at high risk of pancreatic cancer. Pancreatic cancer surveillance of high-risk individuals is becoming more common worldwide, aiming at anticipating a diagnosis of pancreatic cancer at a preclinical stage. In Italy, in 2015, the Italian Registry of Families at Risk of Pancreatic Cancer was created. And the aim of this study was to assess the prevalence and incidence of pancreatic findings, oncological outcomes, 7 years after the inception of such a registry in Italy. This was a prospective study conducted between 2015 and 2022 in Italy. This is a nationwide program where high-risk individuals for pancreatic cancer, those with family history or mutation carriers, are enrolled in 18 centers across the country. And these authors for this study included patients with at least 3 years of surveillance. These patients underwent annual MRI or endoscopic ultrasound, and the primary outcome was looking at the incidence of pancreatic cancer. So as you can see, the patients included in the study comprised 156 patients who underwent surveillance for pancreatic cancer. And if you look at the patients who were included in the study, 18.6% had family history of pancreatic cancer, and the rest were mutation carriers and with family history of pancreatic cancer. And mutations included BRCA2, P16, CDKN2A, BRCA1, PALLB2, and PRES1, and Peutz-Jeghers syndrome. Now, if you look at those included in this study, 156 patients underwent pancreatic cancer surveillance in this nationwide program in Italy. The median age was 51, 54.5% were female. The mean body mass index was 23%. If you look at smoking history, 14.1% were current smokers, 18.6% were non-smokers. And patients who were smoking, the median number of years of smoking was 15 years. The alcohol intake of at least 21 units per week was 1.9%. Those consuming less than 21 units per week was 23%. 1.9% had diabetes, and 1.9% were all on anti-diabetic medicine. And the personal diagnosis of pancreatitis was seen in 0.7%, and also 17.3% had a personal history of malignancy. Now, when they looked at the individuals, they found malignant and pre-malignant lesions in 9 individuals in the 156 patients who underwent surveillance. 5 of 8 cases of malignant lesions occurred in pathogenic variant carriers, 4 in familial cases. 3 of 8 pancreatic cancers were stage 1, 5 of 8 pancreatic cancers were resectable, and the cumulative risk cumulative risk for pancreatic cancer at 1, 2, and 3 years was 1.7, 2.5, and 3% respectively. So the take-home point from this study is that pancreatic cancer surveillance in a fully public healthcare system is feasible, safe, and leads to early pancreatic cancer or pre-malignant lesion diagnosis. So recap from this month's GI Journal Club: contamination of reusable duodenoscopes remain as problematic and resilient issue for which to date no solution has been identified. And even though several interventions were carried out over time, it did not lead to elimination of contamination. Changes in reusable duodenoscope design that facilitates sterilization or disassembly might be critical for effective endoscope reprocessing and prevention of duodenoscope-associated infections. In patients taking direct oral anticoagulation, PPI co-therapy was associated with lower risk of hospitalization for upper GI bleeding and upper GI bleeding requiring transfusions. Benefit of PPI co-therapy on hospitalization for upper GI bleeding was consistent among different subtypes of direct oral anticoagulation. And given that most frequent single site of direct oral anticoagulation-related major bleeding is the GI tract, use of PPI in direct oral anticoagulation receiving patients for gastroprotection as primary GI bleeding prevention strategy could be a reasonable option. Finally, pancreatic cancer surveillance in a fully public health care system is feasible, safe, and leads to early pancreatic cancer or pre-malignant lesion diagnosis. Thank you again so much for joining us in this month for the Orlando GI Journal Club. Our next GI Journal Club is on the first Wednesday of June, which is June 5th. 2024. We will start at 7 a.m. Eastern Standard Time. Thank you so much. Have a wonderful day, week, and month. We will see you next month. Thank you so much. Bye.